And if you have questions that you don't want shared publicly, you can mark them anonymous, but we will get to that in just a moment. So let's get started. So just an introduction slide, we will be sharing this recording with the broader community after we wind up this evening. We wanted to make this presentation available specifically for our volunteers because we value so much the time and energy that our volunteers give us. And we know that you work with our community one-on-one in a lot of different capacities. And so the ability for you to understand and have knowledge about public policy, laws, and how they interact with coverage is so important. We wanted to make sure that you were the first to have this information and to have the ability to ask questions. So as you know, we have our 4-pillar programs. You all work and engage in those various pillars, especially in our support arm of our efforts, as well as public policy and research. So we so appreciate that, and just like to show this to show all the different types of things that we do as an organization and the different types of things we engage in on behalf of people with or at risk of hereditary cancers. So I should introduce myself. My name's Lisa Schlager, and I am the Vice President of Public Policy for FORCE. Essentially, my job is to set the priorities for the issues that really affect the hereditary cancer community. And when we say the hereditary cancer community, we mean people with cancer, but also people who are at high risk of cancer due to their inherited genetic mutation or family history of cancer. The work we do historically has been at the federal level, because federal laws and federal policies very much influence things like healthcare and privacy. But in the past year or two, we've also gotten heavily involved in state public policy work, and we're finding that that is a very impactful way to make a difference in the lives of constituents on a state-to-state basis if we can't make a change at the federal level for whatever reason. And sometimes it's just challenging with the way that Congress works. So I'd like to introduce my colleague, Lisa Peabody. She was brought on board to help us manage those state efforts, and I'd like to ask her to unmute and introduce herself.
Hi, I'm Lisa Peabody. It gets confusing because we are the Lisas, both Lisa Peabody and Lisa S. And I manage the PALS program, which stands for Patient Advocate Leaders. And there are trained volunteers who we deploy when we're working at the state level and we need stories to be shared with the lawmakers or testimony to be written, submitted in support of a piece of legislation that helps the hereditary cancer community. And I've been at Force about 1.5 years now, and I'm really it's nice to see so many pals on the call, but it's a really exciting program that we enjoy. Thanks for being here.
Thanks, Lisa. And I want to say that we wanted to include volunteers beyond our patient advocate leaders, because we know peer navigators, helplines, support group leaders all encounter questions from members of our community about coverage and the laws, and also just personally as people who are impacted. It's good for us to understand how all these things fit together for our own care and the care of people in our families. So just a few ground rules or housekeeping. We're going to ask that that you try to keep yourself muted during the presentation so that we don't have background noise. We will have a discussion. We'll be doing Q&A after the presentation. So if you can hold your questions, or if you just prefer, you can put them in the chat. We will be checking the chat throughout and compiling those questions. and then we will address them after the presentation. So, you know, if you're afraid you're going to forget something, write it down, put it in the chat, and we're happy to just sit on it and address it later in the evening. As far as questions go, we understand that everybody has unique experiences and probably some unique questions. Tonight, we don't have time to address very specific questions like those that relate to a very, a specific state law. It's just not possible with 50 states and dozens of laws that affect the community in each state. We can't necessarily address very specific individual situations or dilemmas or things that are related to a particular insurance plan or policy. We were looking, really for a bigger picture that we can address that affects the broader community. However, we understand that there might be specific questions. And if you do have specific questions, we encourage you after the presentation, if there are things that weren't addressed that you're unsure about, please email us at the PALS email address. So it's PALS for Patient Advocate Leaders at facingourrisk.org. And we will do our best to get back to you to address those specific questions to the best of our ability. And if Lisa Peabody and I are not able to address them, we will certainly reach out to our guest speaker or others to ensure that we can get the answers that you need. So before we dive into the presentation, I wanted to mention that all of you may come away from tonight saying, how can I help? How can I make a difference? How can I know what Force is doing? Or, so we wanted to just share a few things about Force public policy. On our website, you can find this graphic. We try to update it each year, although I will admit our policies tend to stay pretty consistent. As you can see, ensuring affordable access to care is really a top issue for us, but also things like genetic privacy and protections, patient safety when it comes to medical devices. Obviously, accelerating research is important to us, and ultimately, reducing health disparities is something that we look at across the board in all of our work. As you can see, we're going to be talking about public policy. Well, the reality is that in a lot of cases, cost translate to barriers. And so a lot of the work we do focuses on reducing or eliminating out-of-pocket costs for services that are needed by the high-risk hereditary cancer community. Again, on our website, we have a section for public policy. And you can see on the left is a screenshot of some of the issues that we've worked on recently. These are high-level issues. We're doing different things literally on a weekly basis, but you can get a summary of those issues and how they impact the members of our community. And then if you are interested in being proactive and taking action, you see this Take Action Now button. That will take you to our grassroots advocacy platform. And this is a special platform that allows you to reach out to your federal or state lawmakers, depending on the issues. And what we provide a pre-written email that you can customize, and you can tell them why certain issues are important to you and why you would like them to support you or support us with particular pieces of legislation. Our lawmakers need to hear from us to understand that the legislation before them really does affect their constituents. So these are just examples of some of the campaigns we've done that relate to issues that affect our community. We use these graphics a lot of times on social media. If you're active on social media, sharing them can always be a good way to spread awareness and to help the cause as well. And finally, we're going into our third year of our Federal Advocacy Day. We are keeping it virtual because it makes it easier for members of our community from across the country to participate without big out-of-pocket costs. Even though it's virtual, it costs us as an organization about $15,000 or $20,000. So you can imagine, the cost that would be involved if it was in person. But with COVID, it's become very commonplace for people to have virtual meetings with lawmakers. So please mark your calendars. We ask typically for about a 90-minute commitment, 90 minutes to 2 hours during that day, to have meetings with your federal lawmakers, and we help prepare you with all kinds of resources so you feel confident going into those meetings, and you don't go in those meetings alone. Typically, you are paired with other members of the community and sometimes healthcare professionals. So please think about that as the date gets closer. We will be opening registration probably in the next month. And finally, I want to introduce our guest speaker today, Joanna Fawzi Duran, who is an incredible attorney. She's the Chief Executive Officer of Triage Cancer.
So while we're getting the slides up, it's nice to be with you all this evening. I was doing a meeting earlier today, and I realized that this is actually my 30th year of working in the cancer community. And one of my very first jobs was actually working at the Positive Appearance Center at a cancer center and fitting patients for mastectomy bras and prostheses. So I have been doing this work in helping people navigate insurance coverage for the cost of care for a very long time. And so I'm happy to pass along some of that information to you today. I would like to tell you a little bit about Triage Cancer. We are a nonprofit organization that provides free education on all of the legal and practical issues that come up as a result of a cancer diagnosis. And when I tell people that I am a cancer rights attorney, I always get kind of a funny look. And people inevitably ask me, well, what's legal about cancer? And I say, everything. Everything about cancer is legal. And it really comes from the idea that if the Food and Drug Administration approves a treatment, that's a legal issue. If your insurance company covers that treatment, that's a legal issue. If you can take time off work to get access to that treatment, that's a legal issue. So it's a lot of things that we don't think of as legal issues, but actually there are laws that provide protections and create programs and give us access to benefits that's important to understand so that you can get what you need. Now, Triage Cancer does provide that education in lots of different ways. We have educational events, we have tons of materials and resources in lots of different formats, and then we have state-specific information on our website. We also offer a free legal and financial navigation program where we can answer individual questions. But most of what we are teaching people is actually not specific to the cancer community. And so this year, we actually rolled out a program called Triage Health, which makes much of the information I'm going to share with you tonight and that we have available at Triage Cancer, available through Triage Health, where it doesn't talk about cancer. And in fact, we often say that a lot of what we are teaching people are all the things that we should have been taught in high school, but we haven't been. So things that just everybody should understand about how to navigate healthcare. At Triage Cancer, we think that when we're talking about managing finances after a serious medical condition, that one of the most important things is to understand your health insurance coverage and to have adequate health insurance. The problem in talking about health insurance is that no one in the United States actually understands health insurance. And it used to just sort of be my anecdotal opinion, but now there's plenty of data that backs that up. In fact, 96% of Americans can't define the 4 key terms used in health insurance coverage. So if 96% of people can't define the 4 key terms that are used in health insurance, how can we expect people to actually be educated healthcare consumers? So it's not at all surprising that only 40% of Americans feel confident that they can pick a health insurance plan that's best for them. And I would actually say that they're probably overly confident because if they don't understand those 4 key terms, then they don't know how to effectively pick a plan for them. Okay, so in the United States, there's only 3 places where we get our health insurance coverage. We're either getting it directly from an insurance company, we're getting it through the government, and by that I mean Medicare, Medicaid, military, veterans care, state or local programs. But still about 50% of people in the United States get their health insurance coverage through their employer. And it's important to realize that all the laws that we talk about and all the programs that we talk about, the laws apply differently to these different types of health insurance. So the protections you have access to, the benefits that you have access to are going to be very different based on the type of health insurance coverage that you have. And I'm going to point to where some of those differences might be tonight. So I want to start with talking about a few of those key terms that are important for people to understand related to health insurance. And when we're talking about insurance companies and buying health insurance, most health insurance companies have a specific group of healthcare providers that they contract with to provide services for a set rate. And if you go to providers that are outside of that network of providers, you're likely going to pay more to get access to that care, or you're going to pay 100% to get access to that care. Now, the contracted rate that insurance companies and providers negotiate is called the allowed amount or the contracted amount for a specific type of service. There are also terms that relate to the cost of having health insurance coverage. So just to have health insurance, we have to pay to have the insurance, even if we got no medical care during the year. And we typically pay a monthly premium to have health insurance. But then there are costs that we have to pay when we actually use our health insurance to get medical care. And the first is our annual deductible. It's a fixed dollar amount that we have to pay first before our health insurance coverage kicks in. So you might have a $500 deductible, or you could have a $5,000 deductible, or you could have no deductible, depending on the type of plan that you have. And then there's something called a copayment. And this is a fixed dollar amount that you pay when you get certain types of care. So you might have a $25 copayment to see a primary care physician, or a $50 copayment to see a specialist, or a $500 copayment if you go into the emergency room. And that's different from coinsurance or cost share. Those 2 terms actually mean the same thing. We often find when we're talking about health insurance that there are terms that actually mean the same thing. And then there are terms that are used the same way that don't mean the same thing, just to make it super simple for us to navigate. So when we talk about coinsurance and cost share, it's a percentage. It's the difference between what insurance companies pay for our medical expenses and what we pay. So if you have an 80-20 plan, the insurance company is going to cover 80% of your care and you're responsible for 20% of the cost of that care. Probably the most important thing for anyone to know about their health insurance coverage is their out-of-pocket maximum. Because in a worst case scenario, it's the most that you're going to pay out of pocket for your medical expenses during the year. So it allows you to sort of plan around that worst case scenario of what you would have to pay for your medical care. And the way that you reach your out-of-pocket maximum is actually a math problem. So you get to add up what you pay for your deductible, plus any co-payments that you make, plus any co-insurance amounts that you pay to help you reach your out-of-pocket maximum. And when you reach that amount, then your insurance kicks in at 100% for the rest of the year. So to give you an example of how this actually works, here we have Dan, who has a plan that's a $2,000 deductible. It's an 80-20 plan, and he has an $8,000 out-of-pocket maximum. So he spends a week in the hospital and he walks out with a $102,000 hospital bill. Assuming he's had no other medical expenses during the year, how much does Dan actually have to pay for that $102,000 bill? Anyone know? You can put it in the chat. Well, first he has to pay his deductible. It is $8,000, Carrie, and this is how you get there. So first, he has to pay his $2,000 deductible, but that leaves him with $100,000 left of that bill. But he has an 80-20 plan, so the insurance is going to pay 80%, and he's responsible for 20%, which leaves him with a $20,000 bill. But how much does he actually have to pay of the $20,000 bill? This requires a little bit of math. I feel like it's too late in the evening to have to do math. So he's already paid his $2,000 deductible, and he has an $8,000 out-of-pocket maximum. So he subtracts the $2,000 and he has $6,000 left that he has to pay out of pocket before he reaches his out-of-pocket maximum, which means that then his insurance will kick in and pick up the rest of that $20,000 bill. So I'm not suggesting that $8,000 isn't a lot of money, because it is, but it is better than having to pay the full $20,000, or if you didn't have insurance, having to pay the $102,000 bill. So again, it lets you sort of plan around that worst case scenario. But as when we talk about the law, the devil is in the details. So it's important for you to understand how your specific plan handles out-of-pocket maximums. Because if you have a family plan, you might have an individual out-of-pocket maximum, and then you might have a family out-of-pocket maximum. And if you have a marketplace plan, you actually have the most protective type of plan, where you get to add up your deductibles and your co-payments and your co-insurance amounts for both any medical care that you receive and your prescription drugs. So it all gets included to help you reach your out-of-pocket maximum. But with employer plans, they're allowed to carve things out. So some employers don't include deductibles to help you get to your out-of-pocket maximum. Some employer plans don't include deductibles or co-payments to help you reach your out-of-pocket maximum. And then some employer plans actually have a separate out-of-pocket maximum for prescription drugs. So you have to add those two things together. So it's important for you to know specifically how your plan handles out-of-pocket maximums, so you can kind of figure out what you're actually having to pay out of pocket. Now, there's two other things that are important for you to know about your plan. If you have an employer-sponsored plan, you need to know when it started. And that doesn't mean when you got the plan, it means when the employer got the plan. So for employers who have policies that were issued prior to March 23rd of 2010, which for those of you who are not familiar with that date, is the date that the Affordable Care Act was signed into law, your plan is grandfathered, meaning that some of the legal protections I'm going to talk about don't apply to your plan. It is pretty unusual to find grandfathered plans now 14 years later, because if the plans make changes to those plans, then they lose their grandfathered status. So over time, lots of plans have stopped being grandfathered. We usually still see some in like large healthcare systems as employers, and some cities often still have grandfathered plans. Then the second thing you need to know about your employer plan is it a insured plan or a self-insured plan? So when an employer buys a plan from an insurance company for their employees, that's called an insured employer plan. So the employer is insured and is providing that coverage to their employees. But some employers don't go and buy a plan from an insurance company. Some employers say, we're going to set aside this pool of money to pay directly for the cost of our employees' care. But we kind of don't want to have to deal with the paperwork. So we're going to hire this other company, what we call a third-party administrator, to handle the billing and the claims paperwork. What becomes confusing about this is that they hire insurance companies to do that work for them. So you might have a card that says Aetna on it, but Aetna is only handling the claims for your employer's self-insured plan. So you don't actually have an Aetna plan, they're just doing the paperwork for your employer. So to give you an example of what this looks like, here we have a standard looking insurance card for Betty don't want to pay from BN Star. And we are trying to figure out, does Betty have an insured or a self-insured plan? Does anyone have any thoughts? It's confusing, right? I mean, it looks like every other insurance card. However, it is self-insured because it says here at the bottom, they provide claims processing only and assumes no financial risk for claims. So we're supposed to know from this kind of cryptic, like small print at the bottom of the card, sometimes even on the back side of the card, that this is a self-insured card. So again, it's important for you to know if your plan is insured or self-insured because the laws apply differently. And we're going to talk more about that in a little while. In the United States, we have two different models for payment systems in our healthcare system. There's the fee-for-service payment system, which is where you go and get care from a provider and your insurance plan pays for that care. Then we have the managed care system, where that system is set up to manage the costs for that company by structuring contracts with providers and limiting the types of providers that you can go to through that plan. So there are pros and cons to these systems, and they exist in the private insurance market. They exist in the individual employer market. They exist in Medicare. They also exist in Medicaid. So you might find these two systems in your state across all of these different types of insurance. So there are different types of managed care plans. And I'm sure you've probably heard of an HMO before, or a health maintenance organization. And an HMO is a managed care plan where there's a specific group of providers that you can go and see. When you go to get care, you have to start with a primary care physician. So if you have a rash, you don't go straight to the dermatologist, you start with your primary care physician, and then that physician refers you to a specialist like a dermatologist. Some of the benefits to HMOs are because they are managing costs, there's often lower out-of-pocket costs and lower premiums for HMO plans. Then we have, on the other end of the spectrum, PPOs, or preferred provider organizations, which have larger networks of providers, still a network, but much more choice in terms of the providers that you go to. And in exchange for that choice, you're paying more for that plan in terms of premiums. One of the benefits is that you have more choice, but you also don't have to have a primary care physician, and you can go straight to that specialist. So sometimes that's worth people paying more for that type of access. And then in the middle, we have an exclusive provider organization, or an EPO. And this is like a PPO in that there's a larger provider of network a larger provider network, which gives you more choice of providers. And you aren't paying as much for a PPO because a PPO might actually have some out-of-network coverage. So if you're getting, if you have a 90/10 PPO plan, maybe it will pay 50% if you go out of network. Whereas an EPO gives you access to that broader network, but no out-of-network coverage. So it is only allowing you to use that provider network. And that's why it's the exclusive provider organization. So again, all of these are different options and could look very different based on where you live and the types of plans that are available to you. So people often ask, well, which is better? And there isn't a one size fits all. It's based on the type of care that you need and the plans available to you where you live. There is one more type of plan that I want to mention, and that's a high deductible plan. And while we might all feel that our plans have high deductibles, having a high deductible health plan is a specific legal term, and it's actually determined by the IRS. So the IRS has designated a high deductible plan for this year as one that has a deductible of at least $1,600 for an individual or $3,200 for a family. We see that more and more employers are picking these types of plans because they have lower premiums, but they have these huge deductibles. And that's obviously really challenging for employees who need access to care. One of the benefits to these plans is that if you have a high deductible plan, you are also eligible to have a health savings account. Now, that's exactly what it sounds like. It's a savings account where you can put money into it to pay for your out-of-pocket medical care, like your deductible for your high deductible health plan. But there are some rules. You can actually start an HSA through your employer, or you can go to a bank and start your own HSA, but you can only do that if you have that high deductible plan. And when you get paid through your employer, you can set aside money out of your paycheck pre-tax, meaning that you're not being taxed for that money, so that it actually lowers your tax burden to put that money into the savings account. The challenge is obviously you have to have the money to be able to save the money in the savings account. And so for many people, there isn't extra money available in their paycheck to be able to put it in the savings account. So not only do they not have the savings account, but then they have the high deductible plan. So that poses some really practical challenges for people. There's also something called a flexible spending account, but that's only something that employers can offer, and it isn't tied to a high deductible plan, where again, you can put pre-tax dollars into that savings account and then pay for out-of-pocket healthcare expenses. So those are the two different types of health savings accounts. Another place where there's a lot of confusion is between Medicare and Medicaid, and what the differences are between those two programs. So Medicare is the federal health insurance program that's only available to individuals who are 65 and older and eligible for Social Security retirement benefits, or for people who have been receiving Social Security disability insurance benefits for 2 full years, or anyone who has end-stage renal disease or ALS. Those are 2 medical conditions that automatically qualify you for Medicare. About 20% of people in the United States actually get health insurance coverage through Medicare. So it's a pretty large group of people. And I could probably spend 8 hours talking to you about Medicare. So we have a lot of resources at Triage Cancer to help you understand Medicare choices if this is something that you might be becoming eligible for or currently need to understand your plan choices. Medicaid is the other federal health insurance program that is available for individuals who have a low income level, and in some cases, also a low resource level, meaning your assets. So about 1 in 4 people in the United States actually get health insurance coverage through Medicaid. So again, a pretty large group of people are getting health insurance coverage in this way. And while it's a federal program, it's administered at the state level. So theoretically, every Medicaid program should look the same because it's a federal program, but that's not the case because states can actually apply for waivers from the federal government to customize their programs. So you might hear someone's experience with Medicare be very different than someone who lives in another state, because the programs can look different, what people qualify for, the benefits that are covered, everything about the Medicaid program can be customized to the state. So even though 2 people in 2 different states might be on Medicaid, it might look very different in their state. So at Triage Cancer, we feel really strongly that people understand all of their health insurance options, because you can't really effectively compare your options unless you know what they are. So understanding what all your options are is important, because then you can actually make some educated choices about which plan is the best for you. Even if you get your health insurance coverage through your employer, if you get your coverage through your employer and it doesn't cover your providers and it has high out-of-pocket costs and it's not working for you, you may have other options. We don't have to take our employer coverage, but you don't know that unless you look to see what else is out there. So we do have a lot of resources to help people understand their health insurance options. So I want to give you a tool to actually help compare your options once you've figured out what they are. And I'm going to walk you through this exercise that is relevant if you're comparing marketplace plan options, if you're comparing choices that your employer gives you. You can compare what your employer gives you to the marketplace, and you can also compare Medicare Advantage plans using the same exercise. So here we have 3 plans, and there is a bronze plan at $200 a month with an $8,000 out-of-pocket maximum, a silver plan at $275 a month with a $6,000 out-of-pocket maximum, and a platinum plan at $400 a month with a $2,000 out-of-pocket maximum. So assuming that you're going to hit your out-of-pocket maximum during the year, because when we're talking about the cost of a serious medical condition, the likelihood is pretty high that you will hit your out-of-pocket maximum. Can you tell just by looking at them which is actually going to cost you the most by the end of the year, or the least? No, you can't tell just by looking at them. You actually have to do the math. And the way that you do the math is that you take the monthly premium and you multiply it by 12, because that's how much it's going to cost you to have the plan for the year. And then you add that to the out-of-pocket maximum, because that's the most that you're going to spend out of pocket during the year. And then that's going to tell you your total annual cost. So here, even though we get sticker shock with looking at the monthly premium cost for the platinum plan, it actually ends up saving us a couple $1,000s by the end of the year. And unfortunately, when most people are shopping for health insurance, they're only looking at the monthly premium because they don't know how out-of-pocket maximums work. And so that's why it's so important to do the math, is because then you'll figure out which plan is actually going to cost you the least by the end of the year. But it isn't just cost that you should be looking at. You also want to make sure that any plans that you're looking at actually cover your providers and the facilities that you want to go to, and any prescription drugs that you take. Because if you pick a plan that doesn't cover those things, then you're going to be paying a whole lot more out of pocket, and the plan's not going to be all that useful to you. So it's important to keep in mind looking at those things as well. And when you're shopping on the marketplace or for Medicare plans, those online tools actually give you the ability to look that information up. So once you've narrowed down a plan, you can actually look to see if your providers and your facilities and prescription drugs are actually covered by that particular plan. So this is just an example of what the marketplace looks like. And then, as I mentioned, Medicare has that tool as well. So at Triage Cancer, we have some tools to help you actually figure out how to pick a health insurance plan, including a worksheet to help you do the math. So you can take 2 different plans and actually fill in the worksheet to figure out which plan is going to cost you the least. And we have that worksheet for private insurance, and then we also have that available for Medicare. So I want to turn for a minute to some of the consumer protections that exist in health insurance. And the ones I'm going to talk about tonight are specifically included in the Affordable Care Act. We often forget, given that this law was passed in 2010, that there was a day where insurance companies could deny us health insurance coverage if we had a pre-existing medical condition. And after January 1st of 2014, so we had to wait 4 years for this to go into effect, the Affordable Care Act said we're not going to let insurance companies deny people based on pre-existing conditions. But when we talk about that protection for pre-existing conditions, there's 2 key parts to it. And the first part is that it changed the way that insurance companies decide how much to charge us for a policy. And that process is called premium rating. So before the Affordable Care Act, insurance companies could look at whatever they wanted to when pricing a policy. And now they can only look at 4 things: whether or not you're buying a policy for an individual or family, because if you're covering more people, they can charge you more; your geographic location based on your zip code; your age, but they can only charge you up to 3 times more as you get older than a 21-year-old. So they put a cap on how much you get charged as you get older. Previously, there was no cap. Every birthday, your plan would exponentially go up. And then if you use tobacco, you can be charged more for your health insurance coverage. And then some states passed some state laws to say we're not going to look at that either. So what's missing from this list? Thoughts?
Pre-existing?
Yeah, pre-existing conditions. So they can't look at pre-existing conditions anymore to charge you for your coverage. The other big thing that's missing is gender. Women have always been charged more than men for health insurance coverage, and that is no longer allowed under the ACA. So then the ACA went a step further and said, we're not going to let insurance companies deny people coverage based on their age, their gender, their pre-existing conditions, where they live, or anything else. If someone can afford the policy, then the insurance company has to provide it. So these two things together are really what created the pre-existing condition protection. Unfortunately, when we talk about protecting the pre-existing condition protections in the Affordable Care Act, people are only focused on the second piece. But the second piece isn't really a protection unless it includes the first piece, because it's not really a protection to say insurance companies have to sell you a policy if they can charge you whatever they want for it, because then they can just price you out of the market. So the pre-existing condition protections are really these two things together, and we're totally and completely game-changing for the healthcare community. And I'm not even talking about the cancer community. I mean, any type of medical condition, whether it be asthma or allergies or diabetes or obesity or high blood pressure, all of those things were reasons that people were denied health insurance coverage before the Affordable Care Act. So the ACA also had some other really important consumer protections that I want to talk about tonight. One of the things that the ACA did was say, we want people to use preventative healthcare services and to get access to screening coverage. The problem is that even if it's covered by insurance, the out-of-pocket costs to get that care is a barrier for people. People aren't going to go and get those screenings if they have huge out-of-pocket costs, especially in a high deductible health plan, for example. So it eliminated those out-of-pocket costs for a key group of preventative services. And it's many of the things that you would expect in an annual checkup, like blood pressure, cholesterol, diabetes, cancer screenings, flu shots, immunizations, all of those things are on the preventative care list. And actually, I've included the link to healthcare.gov where you can find the full list. But it included preventative services that were tied to the U.S. Preventative Services Task Force. So this is a task force that gets to decide what types of preventative services is it important for people to get access to. And the way that they decide importance is by grading those services for different patient populations. And the law is tied to the task force rating of A or B. So only the things that get rated as A or B ratings by the task force end up being zero out-of-pocket cost under the ACA. So it's a very important connection in the law. The only exception is actually mammography. And that's because of one female senator, Debbie Stabenow from Michigan, who fought to have this exception written into the Affordable Care Act to say that we're not going to look at mammography at 50 or older as free, but we're going to drop that age down to 40. Now, the task force has changed guidelines since then, but when the law was passed, the 40 or older rating wasn't an A or B rating from the task force. So the interesting thing about the law is that when legislators write the law, they sometimes word things poorly, or they don't necessarily think things all the way through. So the way that the law was written was that genetic counseling would be covered at zero out-of-pocket cost, but the testing wouldn't be. So here we've talked about the counseling, which might recommend testing, but then people couldn't get access to the testing with zero out-of-pocket cost. So that's a good example of how the advocacy community stepped in. And in January of 2013, HHS came out and revised their language to basically say, that's not what we meant. We meant for testing to be included as well. And so we got a rule from HHS that now covers counseling and testing at zero out-of-pocket cost for
Joanna, I
individuals.
want to clarify that that only applies to BRCA genetic testing.
Right, so that's the point.
So it's only for BRCA1 and BRCA2, and only for women who are not currently in active cancer treatment. So that's a very, very important distinction for our community.
Yes, and again, that's how the task force framed the rating. So the coverage is tied back to how the task force frames the rating. Another example is around colonoscopies, where it covers colonoscopies as a preventative colonoscopy, meaning that when you go in to get your screening colonoscopy, you don't have any symptoms and you're just going in for a screening. The whole point of going in to get a colonoscopy is to see if you have polyps and to remove those polyps so it doesn't become cancer. This is an example of where the law did not think that through, and insurance companies were basically charging patients for diagnostic colonoscopies if polyps were found during the colonoscopy. So you'd go in for your colonoscopy thinking you have zero out-of-pocket costs, you wake up, find a polyp has been removed, and now all of a sudden you're paying for a diagnostic colonoscopy. So again, the advocacy community stepped in and talked about how this doesn't make sense, and then asked for HHS to revise their language, which they did in that same revision. So specifically for private insurance plans, if a polyp is found during a colonoscopy, it is still a screening colonoscopy and it's still zero out-of-pocket cost. So those are just two examples that are cancer specific of how the law created the protection, but on a practical level, the details needed to be worked out. And that's where the advocacy community was really helpful at pointing out the practical way these laws were being applied. Now, you'll see that little asterisk there. Remember how I talked about grandfathered plans? If you have a grandfathered plan, these free preventive services are something you don't have access to. Your insurance might, well, let me not say it that way. Your insurance will still cover these services, but you're going to pay out-of-pocket costs to get access to these services. And so that's why it's important for you to know whether or not your plan is grandfathered. So I want to just talk a little bit more about the difference between coverage versus something being free. So when we talk about insurance being required to cover something, we just mean that they're required to cover their share of the cost. So if you have that 80-20 plan, they only need to pay 80% and you're responsible for 20% of the cost of that care. But when we talk about things that are free, like those free preventive services, it means that the insurance is paying 100% of the cost, where your out-of-pocket cost is zero. So there is definitely a difference between saying something's covered versus something's free. And so when we talk about how these legal protections apply, that makes a difference. There are laws that require coverage, and then there are laws that require coverage with 0% cost sharing for the patient. So then the question becomes, what do you do if you need access to these services and you don't fall within that ACA US Preventative Service Task Force guideline? Chances are you're going to get access to coverage if it's medically necessary for you to get that care, but it's not going to be free because it doesn't fall within the ACA's protection and the way that it was written because it was tied to the task force guidelines. So if you are under 40 needing a mammogram or you're under 45 needing a colonoscopy and you are high risk, then it's very likely you're going to get access to coverage for that care because it's medically necessary for you to get those screenings, but you are not going to get the free access to that care. The one last protection that I want to talk about related to the Affordable Care Act is about appeals. When an insurance company denies coverage for something, which comes up quite a bit in the context of screening, especially if you are trying to get access to screening and you don't fall within one of those guidelines, it's common for insurance companies to deny things. Unfortunately, most people take no for an answer, and they don't go through the appeals process. This is specifically going to be about private insurance, because I want to talk about a specific benefit in the Affordable Care Act. So there are legal protections actually across a number of different laws that give you the right to an internal appeal, which means you can go back to your insurance company and say, I'd like you to reconsider your denial, and this is why. My healthcare team has recommended I get access to this care, and it's medically necessary because XYZ. It's also pretty likely that an insurance company is going to still deny it. It's not uncommon for insurance companies to do that. The Affordable Care Act created the right to an external appeal, where you get to go outside of your insurance company to an independent entity and ask them if they think it's medically necessary for you to get access to that care. Obviously, if your healthcare team recommended you get access to some type of care, there's a medical reason for it. So they're a good ally in the appeals process and can help provide information for the appeal. But the benefit of this is that the insurance company isn't the one making the decision. It's an independent entity that's going to look at whether or not it's medically necessary for you to get access to that care. And however they decide, that decision is binding on the insurance company. So if they say it should be covered, the insurance company has to cover it. Now, this process is handled either by the state health insurance agency or by HHS. And on our website, we actually have a chart for each state that talks about who handles what. But the external appeals process is either going to be free or at most $25 for you to actually appeal that denial. It's actually, I've never heard of anyone actually being charged, but the way that it's written in the law is that it's a maximum of $25. I said, though, that most people take no for an answer. And when I mean no people, I actually mean no people. This is data specifically from Marketplace Plans for 2021, where 48 million claims were denied. And 99.9% of people said, okay, I will take that no for an answer. So instead of appealing, even to the first level of appeal, people were fine with their insurance company saying, no, you can't get access to that care, which on a practical level means that's 48 million people who were trying to get access to healthcare that their healthcare team recommended, and they either didn't get access to that care because their insurance company didn't cover it, or they paid for that care out of pocket. And so when we're talking about financial burden of serious medical conditions, people's lack of knowledge about the external appeals process is actually contributing to that. And so this is actually a huge soapbox issue for me, because 99.9% of people are being denied and they're not availing themselves of the protection that the advocacy community worked really hard to create for them in the Affordable Care Act. And so this is a great example of where people work very hard for advocacy efforts and we get these legal protections passed, but then no one knows about them. And so then they don't get the benefit of these protections. So the education piece is as important as the advocacy piece. And to that end, we have a lot of resources at Triage Cancer to help people understand the appeals process and how to actually go about getting access to care. And we have resources for all the different types of insurance someone might have and how to actually appeal denials of coverage. So I want to talk just for a few minutes about other types of insurance. Supplemental benefit plans are often called critical illness plans or cancer plans or accident plans, and these plans are not health insurance. We specifically refer to them as supplemental benefit plans because they're not covering healthcare. They typically are providing cash payments to you because you've been diagnosed with one of these types of medical conditions. So for example, if you have a cancer plan and you're diagnosed with cancer and you have to have surgery, they write you a $10,000 check. It's not actually covering the cost of the care because you can use that $10,000 check for anything. But they might also cover extra things, like they might cover travel to treatment, like paying for lodging or airfare, or even mileage. So some of these plans are actually incredibly beneficial to people to help cover some of the out-of-pocket costs of care. The challenge is that the pre-existing condition protections that exist for health insurance do not apply to these plans. So once you have a pre-existing condition, it is very difficult to buy one of these plans. Not impossible, but difficult. The same can be said of life insurance and disability insurance and long-term care insurance. So I'm going to come back to life insurance in a minute, but disability insurance is a private disability insurance plan that you can buy either directly from an insurance company or through an employer. They can be shorter long-term plans. Whereas long-term care insurance is specifically covering the cost of long-term care. So that care can be received in a facility, like a nursing home or an assisted living facility, or it can be provided in home, where you actually have care providers come into your home to provide that long-term care. And again, you buy this directly from an insurance company. Most people do not proactively buy disability or long-term care insurance in the United States. Most people get access to disability insurance through an employer, and most people don't buy long-term care insurance at all. And so when you're in a position where you need long-term care, you're often spending down your assets and then qualifying for Medicaid to cover the cost of long-term care. So if this is something you want more information about, we have a module on our cancer finances tool called Paying for Long-Term Care. With all of these types of plans, you have to go through the medical underwriting process, which means giving all of your medical information to these plans to show that you can qualify for them. And that can even be weight related. So if you are overweight, according to the BMI chart, you are going to have a hard time getting access to long-term care insurance, or you're going to pay substantially more for it. So some of these rules are very strict in terms of the types of medical conditions that they allow you to have and still give you access to coverage. Then, even if they do give you coverage, they might charge you more, and they might have pre-existing condition denials or exclusion periods, where if you buy a policy and then within 2 years, you actually need to use the policy, they pay you less benefits or they give you access to less. So the protections that exist in health insurance for consumers do not exist for these types of plans. So it's important to keep those things in mind. With life insurance, there are a few more options because life insurance is more common to people than disability or long-term care. And there are some strategies about finding life insurance once you have a pre-existing condition where there might be things that you can qualify for. There is specifically a type of policy called guarantee issue whole life insurance. And those are the types of policies that you often see television commercials about. And where you can't be denied, but you have to be within a specific age range, and they don't pay out a huge amount on these types of policies, but it is something that can help cover costs for your family. Many of them have 2-year exclusions where if you actually pass away within 2 years of buying the policy, they actually won't pay out the policy. They'll just refund you the cost of your premiums up to that point. So it's important to read the fine print if you're looking at these types of plans, but it is theoretically possible for you to be able to find them. So the last thing that I want to leave you with before we take some questions is how states have responded to 3 key access issues. So there's access challenges around getting access to coverage for screening if you don't fall within the ACA's and the task force's guidelines. There are access issues around getting coverage for those services without any cost sharing. And then there's access specifically issues for coverage of risk reducing surgeries, because there's the screenings but then also the surgeries. So the decisions that you're making about your care once you have the screening information to make educated decisions. So the way that insurance handles those different situations is very different, depending on the state that you're in and the type of insurance that you have. And so a lot of times you will find yourself in a position of facing one of those denials, and using the external appeals process is a key way to make sure you can get access to coverage. And when you're filing those appeals, if there isn't a specific legal protection that gives you the right to access that care, then it's about making your best argument. And so it's about gathering medical information, gathering guidelines, talking to your healthcare team, any information that they can provide about why it's important for you to get access to that care and that it's medically necessary is going to help in that appeals process. And so I just wanted, I could have gone on forever talking about all the ways that states have responded to try to provide additional access, but these are just some. And then we do actually have a chart on our charts of state laws specifically around access to breast MRIs. And so these are just some examples of New York and Washington. So with that, I am going to stop talking and actually turn back over to Lisa to see if there are questions.
Thank you so much. I think this was really tremendous information, foundational information that is needed. I think especially for our community, there are so many caveats because of the recommendations that people in our community need, breast MRIs, for instance, starting at age 25, or colonoscopy starting between ages annually versus every 10 years between ages 20 and 25. And so that is a big part of the state work we're doing. And we will be launching actually a map or some sort of tool with state laws on high-risk cancer screenings in later this year. Including breast MRIs, but also prostate screening, colon screening, as well as coverage for multi-gene panel testing with no out-of-pocket costs. The other thing we will be discussing is the ages that those are covered, or if there are any restrictions, and whether cost sharing or meaning you have to pay a portion, or if they are free to you in that state. So we do want to give time for everyone's questions to be addressed. I'm going to let Lisa Peabody sort of manage that. I don't know if she's received any questions that the group had. And then if not, we can open it up. If you raise your hand, we can let you unmute and you can ask questions directly of Joanna. So Lisa, why don't you start first?
Sure. If you do want to, you can either put that question in the chat, or if you'd rather, you can raise your hand. If you hover on the bottom, you can see a spot where there's reactions, and that's where the hand raising tool is. So, and I can call on you that way. I just wanted to ask Joanna, just looking through the questions, what can you define when you mentioned the word marketplace? Can you define what it means for it to be a marketplace policy?
Yes. So one of the things that the Affordable Care Act did to create a new way to buy health insurance was to create state health insurance marketplaces. So every state has a state health insurance marketplace, which effectively is like an insurance shopping mall for private insurance for individuals in their state. About 35 states run their marketplace through the federal government through healthcare.gov. And then about 15 states actually run their own marketplaces. So California, for example, has Covered California is the name of their marketplace. So it's really just one place to go to find your private insurance options in your state. And there are some benefits to actually buying coverage through the marketplace, like you might actually qualify for financial assistance to lower the cost of your monthly premiums based on your income level.
Great, thank you. Another question is, you talked about something about an HSA and an FSA. Are there restrictions on the HSA about how much you can put into the HSA? Are there restrictions on your income and using the HSA?
Good question. So with the HSA specifically, you can only use an HSA if you have a high deductible health plan. It is not based on your income level, but they are capped at how much you can put into for an FSA. And for an FSA this year, it's a $3,200 maximum that you can take from your paycheck and put into the FSA tax-free or pre-tax. And you don't pay taxes on it as long as you use it for qualified health expenses. So you can actually take money out of your FSA and use it for other things, but then you're gonna have to pay taxes on it because you didn't use it for a healthcare expense. And that is true. An FSA is use it or lose it. So you put that money in a maximum of $3,200. And if you don't actually spend it by the end of the year, you have two limited options. So you can either roll over some of it into the next year, or your employer can give you a few more months to actually use that money. But if you don't do either of those two things, you will lose the money you put into the account. Whereas the HSA, it will continue to grow. So you could theoretically put money into your HSA for decades and never take any money out of it. But then when you stop working, for example, then you could actually use the money in your HSA to pay for out-of-pocket expenses.
Great, thank you. That's really helpful. So, let's just set up a scenario where I'm a high risk patient and I need to get a breast MRI, and I go to get my breast MRI and I have to pay, I get a bill for $2,400 and my deductible is $2,000, right? So am I going to pay that entire $2,400 right there, or $2,000? How's that going to work?
So forgive me on the math, but if you have a $2,000 deductible and you have a healthcare expense that's $2,400 where you actually are responsible for the $2,400, yes, you're going to have to pay that full $2,000 first before your health insurance coverage kicks in. So that's why those high deductible plans can be really challenging for people, because sometimes the deductibles are like $5,000. And so that's a lot of money to have to pay out of pocket first before your health insurance coverage kicks in. And that's, again, why it's something to take into consideration when you're shopping for insurance, where you might pick a plan that has a higher monthly premium, but a lower deductible, because the monthly premium, that cost is spread out over the year versus a deductible where you have to pay that all in one lump sum.
I'd like to add that when we're talking about deductibles and out-of-network coverage or 80-20 splits, that unfortunately, a lot of times they use the term reasonable and customary. The insurance company will only consider the amount of money that they say is reasonable and customary for that service. And
right, and
that can be a lot less
that.
than what you were charged.
Yes, and that goes back to that very first term that I talked about, which was the allowed or contracted amount, which is what the provider is agreeing to accept from the insurance company.
Right. So if you go out of network and the provider is charging, $1,800 per procedure, or, but your insurance says, well, that procedure, we only reimburse $800 for that. You're going to be responsible for that. They're only going to help you offset the cost of the 80% of that 800, not 80% of the 1,800. And so that's something to really keep in mind if you're going for out-of-network providers and for services that are not covered in your network or under your insurance. I want to also
question about the HSA, unless is this still about this deductible? We can stay on it. Sorry.
No, please go ahead.
Someone asked if you had an HSA and then you retired and you had some leftover money, from that HSA, can you use that money to pay for Medicare B and gap insurance and all of that other insurance down the road?
So you can use HSA money. So let me just actually start by saying, once you are eligible for Medicare, you are not allowed to add money to an HSA. So it basically stops your ability to add to the HSA, but you can use the money that's in the HSA to pay for out-of-pocket expenses. I would actually have to just double check off the top of my head if you could also use it to pay for a Medigap plan premium, but my gut reaction is yes. But I'm happy to look up that information. I will also just mention that this was a pretty high level introduction to some of this information. And so if you want more information about these topics, we actually have a monthly webinar series that does a deep dive, like 90 minutes just on Medicare. And then we also have our Triage Cancer Conference, which is 2 days worth of information about insurance and employment issues and finances and disability and a number of other topics. So those are free events that you can register for on the Triage Cancer website. And then we also have our legal and financial navigation program where you can talk with our team about any of your personal questions that come up.
That's so important. So as you know, Force has a helpline and we have peer navigation, but a lot of times we don't have the expertise to advise people on the legal aspects and some other aspects of the issues they're having. So we do partner with Triage Cancer. We refer a lot of patients, members of our community to them, not just for cancer treatment, but even denials of high-risk screenings and denials of surgeries. So, you know, they have been incredibly helpful and certainly recommend all of their workshops. They're tremendous. I want to just add on to what Joanna has shared and say that these loopholes, as I would call them, in coverage for people who are high risk is exactly where we as an organization are focusing in our public policy. So things like the genetic protections that we are not afforded at the federal level, we can be denied coverage for life insurance, disability, or long-term care coverage, even just for having a mutation and really for having any medical condition. You could, you know, have a predisposition to heart disease and they could say, we don't want to insure you. But the reality is having a genetic mutation is not 100% guarantee that you're going to get a disease. And so one of the things we are doing is going state by state. Currently, we're working in New York, Maryland, South Carolina, and Illinois to pass laws that would ban the ability of these insurers to use genetic information against us for policies. So that's something, if you live in those states or want to initiate an effort in your state in the future, certainly talk to us, please. I think the other big area we do focus is the coverage for the high-risk screenings. So as Joanna mentioned, the breast MRIs is a big deal. We are partners with Susan G. Komen. We are going state by state, passing laws. I think 5 laws were passed last year, and we were engaged in many of them, where there is no minimum age for breast screening if you're considered at increased risk. And MRIs, ultrasounds, and mammograms are covered with no out-of-pocket cost, which is tremendous because we know those costs prevent people from accessing the care they need. And on top of that, if you have a suspicious mammogram, it would cover the diagnostic imaging. So whatever is needed to actually determine if that abnormality is cancer. So these pieces of legislation are incredible. And we are hoping to expand them to areas beyond breast. So we're also working on eliminating costs for high-risk prostate cancer screening. And one of my dreams is to see the same for pancreatic and colon. Unfortunately, it seems that these types of efforts are broken up by cancer type. We would like to float or attempt to do something in a state where it would cover all high-risk screenings with no out-of-pocket costs. And there is an appetite in one state that we're currently exploring. So if these are things that you have interest in, you want to get engaged in, please reach out to us. We frequently have opportunities for engagement, and we always go to our volunteers first. So I see some additional comments here, but any other, I do want to make a little statement about the differences between Medicaid, Medicare, and private insurance. Each state's Medicaid program and coverage is unique, but we know at this point, every state covers at least some genetic testing, BRCA testing, except Alabama, which we're still working on. They claim they do, but they really don't. And then coverage of the downstream services can vary based on the state. Medicare is a different beast. Currently, we know that Medicare only covers genetic testing if you already have cancer. And we have a piece of legislation in Congress that's trying to change that because that flies in the face of prevention. So people can pay out of pocket, and genetic testing is reasonably priced these days if you go directly to the lab. But once you have that information, unfortunately, Medicare is statutorily prohibited from covering things like risk-reducing surgeries and even high-risk screenings. Now, we see that is not applied equally across the US. In some states, people are able to get things like breast MRIs or risk-reducing surgeries, but then in other parts of the country, they're following the guidelines, and all of those services, the coverage is completely rejected. So we think this is really a travesty. And so there is a federal piece of legislation that would remedy this issue. And we're having trouble pushing it forward in Congress. So anything that our community can do to reach out to their lawmakers and explain how important this is certainly would go a long way. We are trying to demonstrate that this might potentially save the system money by eliminating later stage cancer diagnoses, and in some cases eliminating the cancer risk because individuals can undergo preventive surgeries. So just something to keep in mind, and we will certainly be sharing more information. So I know there must be some other questions out there. We have about 5 more minutes. So last chance.
Yeah, I wanted to ask something, just kind of thinking about this, Joanna. So we know that there's these new state laws that are helping our community with this no cost screening. And as Lisa said, we're still behind when it comes to pancreatic and colon. And I'm really excited. I do want to share that in Vermont, it's the first bill I've seen where it's a no cost sharing high risk colon screening, and we're going to be behind it. We're looking for volunteers in Vermont. We don't have as many in Vermont as we'd like to help move that forward. So if anyone knows anyone in Vermont who's connected to the high risk community. But Joanne, I wanted to ask you, so there's so much movement and change. Does the insurance companies, do they keep up with it? Is part of why sometimes people are denied because they're just not current with the newest law that says it has to be no cost sharing? And I mean, is that part of what that disconnect is?
I would love to say that the reason that insurance companies are denying that is because they're not aware of the law, but I don't know that that would be true. So I mentioned before that I used to fit patients for mastectomy bras and prostheses, and then one of my responsibilities was then to bill insurance companies. And at the time, I was actually also in law school and had learned about the Women's Health and Cancer Rights Act in a course that I took, which is the federal law that requires them to cover that. And it was a relatively new law. It was probably like 4 years old, maybe then, or maybe not even. And the insurance company would say denied, denied, denied. And I would call them up and say, I don't understand. Why is this denied? And then they would say, it's not covered, it's cosmetic. This is not a covered benefit. And then I would say, what about WICRA? And they would say approved. Because all I had
To
to do,
clarify, WICRA is the Women's Health and Cancer Rights Act. And
So-
yeah,
all I had to do was say the acronym of the law, not the full name or demonstrate that I knew what was in the law. But all I had to do was point out the acronym of the law, and then they realized that I actually knew what I was talking about and that they were caught and that they needed to actually provide coverage. And so I don't say it to sound sarcastic, but the truth is that this system is set up to deny. And then if people don't take advantage of their rights to appeal, then they're much more likely to get access to the care. And the advocacy efforts at the state level are so important, but at the same time, they take a long time, as the Lisas can tell you. It's a lot of hard work to get laws passed state by state, medical condition by medical condition.
and we prefer to do it at the federal level, but
Totally. But in the
sometimes it's
meantime,
harder to move things at the federal level, or federally they look to see if there are examples of it working at the state level before they're willing to consider it at the federal level.
right. But in the meantime, if patients actually need access to the care, then that's what the appeal process is for. And so we want people to be using that and making the argument for why it's medically necessary that they get access to that care, so that they're not missing out while the legislative process is going through its process.
So as
Just
Joanna,
another reminder that
yeah.
we really need to appeal. We really
and
need to
Joanna
appeal.
shared, they have a lot of information on appeals on their website, on the Triage Cancer website. I will also note that Force has developed very customized sample appeal letters for services that are specifically needed by our high-risk community. So things like genetic testing, breast MRIs, risk-reducing surgeries, colonoscopy before age 45, citing national guidelines and other insurance policies that do cover it, so that you have the tools you need to be able to file an intelligent appeal. Even then, sometimes the insurers push back, and that's when you can engage experts like the legal experts at Triage Cancer, or there's also another organization called the Patient Advocate Foundation that has case navigators who can work with you on that type of thing. And in the end, also, if you end up with large out-of-pocket costs that you simply cannot afford, there are options, there are assistance programs out there, and don't hesitate to reach out to our organizations and others, because we can figure out a way to help offset those costs, or to reduce payments, or minimize ultimately what you have to pay. So if there are no other questions, I guess that's it for the evening. But I want to thank Joanna again, and I apologize for the technical difficulties earlier. But I think this was tremendously useful. If you do have questions that are more specific to your state, or specific to certain scenarios, don't hesitate to reach out. We shared that email address earlier, and Lisa put it in the chat. If there are more general questions, obviously we have our general email address at Force, and then we would redirect your inquiry to the appropriate team member or volunteer for help. So I think at that, we'll wind it up. Thank you so much for joining us. And Joanna, we can't thank you enough for your expertise and your time. And to all of our volunteers, thank you for everything you do. We couldn't do it without you. And don't hesitate to reach out if you have any additional questions, or if you want to get more involved in advocacy. So thank you again, and we'll say goodnight.